Okay, guys, we're going to go into our environmental emergencies. I'm going to skip through a lot of this stuff, specifically, basically the whole front half of the actual lecture. I want you guys to make sure that you guys understand that the hypothalamus is really what controls all of our thermal regulation. Make sure that you guys know the actual mechanisms that we use to control our thermal regulation. And then I need you guys to know the definitions of conduction, convection, evaporation, and radiation. Okay, so all those kind of little definitions that are out there for you. Make sure that you guys are looking over those. Okay, what I want to spend the time on are the actual emergencies that you guys will get in the environmental, and we will start with hypothermia versus hyperthermia. So the definition of hypothermia is actually when heat is lost faster than it is actually produced. Okay, so this is usually caused by environmental concerns. However, people can become hypothermic based on possible like drug overdoses or medication overdoses or just not kind of taking care of themselves. There's all kinds of different ways that people can become hypothermic. However, we're going to talk about the environmental aspect of this in this lecture. So your core body temperature actually drops below normal. And because of this, your peripherals, all your vasculature and your peripherals, so your hands and your feet, they start to vasoconstrict. They start to redirect that blood to the core in order to keep the organs functioning and keep the big three perfusing, which is respiratory, cardiac, and neuro. It can only do so much, though. Okay, the body can only compensate so much, and that when it stops to compensate, this is usually when people die from hypothermia. So there's actually three different types of hypothermia as far as the onset. We have acute, subacute, and chronic. Acute would be like immersion hypothermia, okay? It's immediate. You guys are walking along a frozen lake and you guys fall in, boom, more than likely you guys are going to suffer from an acute hypothermia. It's such a shock to our body. Subacute is an exposure, so maybe you guys decided to go camping and you didn't take the proper equipment with you. And you guys are out there for a couple of days before you guys actually start to feel the effects of it. That's a subacute exposure. And then we can have people that actually suffer from chronic hypothermia, and it's usually our elderly patients. Our elderly patients, they are getting old, their bodies are starting to shut down, their hypothalamus doesn't really work as fast as it used to, or possibly they have some kind of medical condition or could be taking some kind of medication that's causing this, but they can suffer from chronic hypothermia. This can be over weeks to months. So, guys, I'm going to make this really easy for you guys. The only difference between mild, moderate, and severe hypothermia, besides the temperature of the body, is the level of consciousness in our patient. Okay? As soon as our level of consciousness starts to drop, more than likely we're going into a more severe hypothermia than we thought our patient might be in. However, so for mild hypothermia, we're looking at a core temperature anywhere between 89.6 or 95 degrees Fahrenheit. They will be shivering, okay? Usually it is an uncontrollable shiver, and usually they are still on the AVPU status, okay? Shivering, again, is one of our body's natural defenses, and what we're trying to create energy. We're trying to create heat through the shivering. However, we're also burning energy doing that. And once we run out of energy and we stop shivering, that is a bad sign. We'll kind of talk about that more coming up in these next couple slides. The best treatment for mild hypothermia is get them out of that environment. Let's start actively rewarming our patients. Okay. If they have wet clothing on, let's remove that. Even if we have to get them naked, let's get them completely out of their wet clothing. Let's get them as dry as possible, and let's start warming them up. We all carry heat packs on our ambulances. There are these like little chemical packs that you actually have to crack in order to start the chemical process in them. We want to make sure that we're putting these along the core. Okay, if you guys are ever experiencing some sort of hypothermia, everyone likes to rub their arms and their legs. Who cares about your peripherals? Okay, If you keep the core warm, everything else will take care of itself, okay? So if you guys are stuck in that situation, make sure you guys are trying to keep your body heat in your core, and sooner or later your peripherals will come back too, okay? But we want to make sure that we dry the patient. And if we are doing the heat packs with our quote-unquote aggressive external rewarming of our patient, we want to lay those heat packs in between the patient's groin and probably underneath their armpits, as close to the core as possible, making sure that we actually wrap the heat packs in something. We can't have the actual contact of the container that the heat pack is in with actual skin. We have to have some kind of barrier there, because we can technically burn them, give them a pretty bad chemical burn, but you guys will get more training on that once you guys get into your services. Okay, once we start moving into moderate hypothermia, our core temperature is anywhere between 78.8 degrees and 89.6 degrees Fahrenheit. This is where shivering stops, and this is a very, very bad sign, guys, okay? Shivering stops because the patient has run out of energy, okay? Shivering has stopped because more than likely their glucose is bottomed out, all right? And then the other problem with this is more than likely because the shivering stopped, their LOC has dropped as well, which means that you guys now have no way of giving sugar. So now we have to actively rewarm our patients. We need to really make sure we're getting ALS on our way, because our heart rhythm is going to drop. We're going to start getting irregular rhythms on the cardiac monitor, specifically atrial fibrillation. We're not really going to talk about that too much on the basic level. You guys will get that more as you move up. We're going to drop our ventilatory rate because our heart rate's dropping. Usually that follows each other, remember. And we're going to have a decreased pupillary response. Once we get to severe hypothermia, our core temperature is below 78.8 degrees Fahrenheit. There are absolutely no reflexes on our patients. They are not responsive to pain. Their pupils are non-reactive. They could have little to no pulse, so they could be very bradycardic, if not absent pulses. Their tissues might be stiff and cold. We can have something called the frozen chest, where their chest is actually unable to expand and contract because it's so cold. And the pulses and respirations may be undetectable. So, what does that mean for you guys? Well, if you can't detect a pulse, you need to start CPR. Okay? There's a saying with hypothermic patients. Okay? And I want you guys to remember this, because this is very important. Okay? People are not dead until they are warm and dead. Okay? I'm going to say that again. People are not dead until they are warm and dead. This is going to be a very long code, okay? We need extra hands, okay? We run codes completely different with hypothermic patients than we do with patients that just happen to have some kind of medical incident and their heart stopped and they went pulseless and apneic, okay? People are not dead until they are warm and dead. Remember that, okay? For this test coming up, for the National Registry as well. People are not dead until they are warm and dead. You guys are going to be humping chest for a long time. We're going to be trying to actively rewarm this patient. More than likely, we're going to be transporting this patient to the hospital where we're trying to work them. We're going to have to give a heads up to the hospital, the receiving facility, wherever we're going, in order to get prep for a hypothermic code. There's things called bear huggers out there, which is basically a big old pillow that they kind of stuff this patient into, and they have circulating warm air kind of going around their body all at one time. But people are not dead until they are warm and dead. Please remember that. Cool little slide for you guys, something to help you guys study. Whenever we're talking about moderate to severe, that core temperature is below 89.6. Remember that severe is below 78.8. They are not shivering, okay? And more than likely they are V, P, or U, respectively, on the AVPU scale. And you guys can see this little kind of chart that I have on the bottom. Depending on where they're at with moderate. Once we start getting to moderate, their critical symptoms start to slow. Once we kind of move in from moderate to severe, we go into what's called the metabolic ice box, is that we are so frozen that everything is undetectable at that point. We can't get any vital signs, and then they're going to be completely undetectable, and then the patient dies. Treatments, we need to rock and roll. Do not stay on scene. Throw them in the back of that ambulance. Get that big diesel engine cooking. Let's turn some heat on in the back. Let's get them out of their wet clothes. Let's try to actively cool. Let's try to actively warm them up. Okay. We have to do this very gently, specifically with our cold patients. Any kind of rough handling on our patients can send them into a lethal heart rhythm. Okay. So, yeah, we're urgently moving this patient, but we are slowly moving this patient to our gurney, okay? Seriously, any kind of jarring, any kind of bump can send these people into a lethal cardiac rhythm, and more than likely we're not going to get them back, okay? We want to try to rewarm them as fast as possible, guys. Again, strip them out of their wet clothes, okay? Don't try to take them off all nice and gentle, all right? Let's get our trauma shears off and let's start cutting shit off, okay? We need to get them out of this wet clothes. We need to crank up the heat in the back of that ambulance. Hopefully that big diesel engine is blowing that hot air for us. We need to go, okay? Because more than likely you guys will be working this code all the way to the hospital, or until you guys meet up with ALS, we can start looking at the heart to see what's going on, and then going to the hospital, whatever it is. But remember that you are not dead until you are warm and dead when it comes to hypothermic patients. So some things that are different with the hypothermic patient that we have to keep in mind. We have to verify a pulse for 1 minute. We have to verify a pulse for 1 minute. No more of this feeling for a pulse for 15 seconds and multiplying by 4, or feeling for a pulse for 30 seconds and multiplying by 2. We have to literally hold there for that radial pulse or the carotid or both at the same time, and we have to hold there for 1 minute to see if we have any beats whatsoever, okay? If we have any signs of life, okay? If the cardiac monitor, when you get ALS there, if they're showing any kind of organized electrical activity, we are not going to start CPR. Okay? If they have what's called a frozen chest, we are not going to start CPR. I've never experienced frozen chest. I know some buddies that live in other places that are way colder than us, and they have experienced frozen chest, and they have assured me that you will know when you are dealing with a frozen chest, because you're going to go to thump on this for CPR, and it's not going to thump, right? It is solid. They said it's basically like, trying to find a frozen stack of ribs and trying to crack them. So, again, apparently, I've never seen it. I don't know any of my friends that have seen it out here. But I know some friends back in the Midwest and kind of the East Coast area that said frozen chest is legit. And you will know when you're dealing with a frozen chest. And we also have to limit our defibrillation attempts. Okay. You guys will get a little bit more of that when you guys get into paramedicine on why we're actually doing that. And the reason why we're doing that is because the patient is so cold that we have disrupted their pH balance, that by giving that defibrillation, it can actually jolt their hearts a little bit too much, and start circulating that frozen fluid again and freezing the heart over and over and over again. So it's basically pointless at that point to try any type of defibrillation attempts. Okay, guys and gals, here it is. My as always, my cheat sheet for you guys in order to help you guys study. I would strongly suggest that you guys look at this and make sure you guys know this for the test that's coming up when we do test on environmental. This is a great way for you guys to kind of organize the mild versus moderate versus severe hypothermia. So when we're talking about heat emergencies, the problem with heat emergencies is basically the body is not able to release the heat fast enough. So specifically if we're in a very dry heat or a very humid heat, the body isn't able to the body can only do so much as far as compensation to keep cool. And if it's really hot or if it's really humid, we just can't get rid of the heat fast enough. That's what gets us into a hyperthermic situation. It's most common in the infants and children, because remember that infants and children really aren't good at thermal regulation until they reach the age of about 4 or 5. You'll see some literature out there that says 6 or 7 as well. And then elderly, because they're just getting old, right? Things are starting to kind of shut down. Their hypothalamus doesn't work as fast as it used to in order to help regulate that thermal regulation. Or they could have some other types of medical issues, or possibly on some kind of medications that kind of messes with them being able to lose heat. The minor heat emergency is the heat cramp, and really this is due to dehydration, excessive sweating with loss of a lot of electrolytes. This could be anybody can suffer a heat cramp, specifically when you are exerting in hot temperatures. Signs and symptoms, they usually have a history of this, and they usually have are complaining of some kind of muscle cramp or some kind of muscle tightness. Treatment for this obviously is to stop the activity. The patient needs to rest. The patient needs to be in a cool environment to help rest. We want to try to replace the electrolytes as best as we can, and possibly do some kind of massage to the area in order to kind of break up that lactic acid and make sure that our heat cramp patient is staying hydrated. So heat exhaustion is much more serious than an actual heat cramp. This is actually a mild sign and symptom of shock. Really, it's a you're sweating too much, right? Plus, we're trying to escape the heat as much as possible, so we have widespread vasodilation, okay? So remember with shock, we said it was a heart problem, or a pump problem, a pipe problem, or a fluid problem. Well, this is both the fluid and the pipe problem, okay? So we're sweating too much, so we're losing fluid that way, and our pipes are too big, so that the fluid that we are losing are not creating enough of that back pressure in our pipes in order to help with the actual adequate pressures for perfusion. The big thing with this is we want to definitely stop the activity as fast as possible. We need to modify the environment. We need to get these people to a very cool spot. We need to rehydrate them. We need to do oral rehydration along with IV in order to try to replace the fluids that they have lost, and possibly even replace some electrolytes. Okay, going into heat stroke. Again, just like with mild, moderate, and severe hypothermia, the difference between heat exhaustion and heat stroke is the change in mentation. It's usually P or U on the AVPU scale once we get to heat stroke. Heat stroke, the problem is that your core temperature is greater than 105 degrees Fahrenheit. We definitely need to get you out of the environment. We need to rehydrate with IV fluids, oral rehydration if the patient is awake. We need to take off any of their kind of wet clothes, any restricted clothes. Not necessarily have to cut them off, but we definitely have to loosen like belts, right? Make sure we're loosening up jewelry, stuff like that, and actively cool your patient. This is where you don't, now, okay, let me rephrase that. We don't want to cool them off too quick, because we can cause serious damage also if we cool them off too fast. What we usually do, and you probably see this at some point, is we'll just put the blower on in the back of the ambulance, not necessarily AC blower, but we'll put the blower on and we'll take a bag of saline. We'll actually cut the bag of saline open and we'll drench the patient with the bag of saline and then let the body actually cool that way. Obviously, they would be pretty close to naked while we were doing this in order for them to let that kind of heat escape. But these people need to be actively cooled pretty quick. We just don't want to cool them off too quickly, because we can cause some damage if we do that as well. You guys will get more training on that when you get to paramedic. Okay, again, here's another one of my little cheat slides for you guys. Make sure you guys kind of look over this. Make sure you guys know this for the test that's coming up, or when we do test out on environmental emergencies. This is just another great tool to help you guys study the difference between heat exhaustion and heat stroke. So make sure that you guys are checking this out.